Welcome once again into the Radiopaedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me for the second time in just a matter of weeks, it's like the good old days, it's my co-host Frank Gaylard.
I know. I've missed my regular dose of Dixon. This is great.
Regular dose. You know why I thought we should have 2 episodes this month, Frank?
Honestly, I don't. Why is that?
Valentine's Day, mate. It's
What?
Valentine's Day this Friday.
Oh, no. I better book something.
Book something for me and you, or for you and your wife?
Both. Now I rely on the podcast to make sure I don't get into trouble with my Hermione. Anyway, what do you have planned? Give me some ideas. You're going to surprise your wife? Something saucy?
Saucy. No, we don't really do Valentine's Day in my house. But my wife the other day, she did show me this Facebook memory from 17 years ago, the day that we got engaged. That was probably my peak romantic moment there. It's all downhill after that. Did I ever tell you about how I proposed?
I'm picturing rose petals, candles.
There may have actually been rose petals and candles. There may have been both of those things. So I took the wife of the podcast. At that stage, was just the girlfriend of the podcast across to the Fitzroy Gardens, nice park in Melbourne. And while I'm there, I had I gave a mate the keys to our house, and we had this nice little courtyard out the back of our house. He goes into the courtyard and he sets up this little area, rose petals, candles, etc., and then gets out of there. And so then when we get back home, I kind of fluff around in the car or something and then send the wife of the podcast inside, and she walks in there and goes out and sees this, lit up back courtyard with rose petals and candles. But the main thing that's there, Gaylard, is a 10-week-old golden retriever puppy.
Oh, it was Pablo.
with a little ring attached around her neck. And you can't say no to a puppy.
You can't. Oh, that's fantastic.
I found an engagement loophole. I had some champagne there, but my wife at the time, she did not like champagne. So I also had like an iced coffee Big M there for her. She was like, yes, that's what I want to celebrate.
I've witnessed your wife having changed her mind on champagne since
She has completely changed her mind. You think you're marrying a woman who just wants a cheap iced coffee out of a carton, and then 17 years later, she is ordering the most expensive champagne she can buy.
Well, I'm glad Natalie doesn't listen to this podcast, because your proposal would put mine to shame, which was asked her, and she said, you'll have to ask my father first because they're sort of traditional. So I did. And then we were out riding a bike, and I said, by the way, I asked your dad. He said yes. So we married, and she fell into a bush. That was...
Did I tell you about the first time, one of the first times I met my wife's father? He used to work at an abattoir. And so the very first time I go to visit them, he goes, do you want to come on a tour of the abattoir? And I was like, yeah, okay. Wife and I are both medical students at this time. And so we go on this tour, and I think he's thinking that it's going to absolutely shock me but I've done dissections and stuff like that. So it was all fine. But I have this vivid memory of him walking around the place, and everyone he came across, he was like introducing me to people. He's like, this is Andrew, friend of the family. And then another person, this is Andrew, friend of the family. It's just, I can still remember it.
And this is a bolt gun. It kills immediately.
Yeah, that's what it was like. That was his introduction. So I think that's pretty different to maybe your wife's parents.
I don't know. I got a death stare from my mother-in-law that actually made me pale the first time. I felt blood literally. That was the first time I understood when people say, I felt the blood draining from my face. It was like, because she was an ex-CCU nurse.
Oh, really?
She doesn't listen to the podcast either. If you do, just joking.
Just joking. The real reason for this extra episode this month is not Valentine's Day, Gaylard. It's actually because we've just released a brand new Radiopaedia course over on the website. And the author of the course, Matt Skalski, kindly agreed to come on the podcast with me and to give everyone a sneak peek at some of the topics and teaching points. So that's what we're going to listen to.
Excellent. Skalski's always fun.
Actually, I think we might get into the main segment now, Galen, unless you have something else to talk about. Because I feel like since we've been doing monthly rather than fortnightly episodes, it's meant that we just do longer intros and outros. We have the same amount of content and things to say, just less episodes to say it in. There's some kind of paradox at play here, like a social availability paradox or something.
The natural extension of that is that we should do a once a year 10-hour podcast.
Yeah, that's it. Just one podcast a year, 10 hours,
done.
5 hours of Gaylard goats, a whole paddock full of goats. Anyway, let's get into the main segment now. So we're going to learn a thing or two about musculoskeletal calcifications from the great Matt Skalski, and then Frank and I will be back with some more bromantic chat in the outro. Joining me now in the reading room all the way from Wisconsin in the United States, it's MSK radiologist, master illustrator and radiology educator. It's Matt Skalski. How you doing, Matt?
Hey, I'm doing great. Happy to be here. I wish I was in Australia right now doing this in person.
Be careful what you wish for there, Skalski, because it's I'm in Melbourne and I've done the conversion for you into Fahrenheit. It's currently 104 degrees Fahrenheit here, which is 40 degrees Celsius. So it's not that pleasant.
Oh yeah, that's a scorcher. It's the exact opposite here. We had a couple days in the last week that were minus 40 degrees Fahrenheit with the wind chill, which I also looked up, which is ironically also minus 40 Celsius.
I can't even imagine how cold that is. We never get that. We never get below freezing in Melbourne. So,
really?
4 or 5 degrees Celsius would be like the lowest we get throughout the year. So,
Wow.
Yeah, I can't imagine that.
Yeah, they canceled school.
Oh, really?
Mm-hmm.
Now, 40 degrees here, they still make the kids go to school. Harden up. Anyway, as has become customary, Skalski, each year you record an extended 90-minute or so image interpretation lecture for Radiopaedia, which we then adapt after the conference into a course with case examples and MCQs and annotated review cases. And so this month, you've just released your latest course, which is all about musculoskeletal calcifications. And so to promote the course, and, let's be honest, to piggyback off of it a bit, I thought I'd get you on the podcast to discuss a few topics from the said course for our listeners.
Yeah, for sure. Let's do it.
So what I've actually done, Matt, if it's okay with you, I have gone and clipped out 6 or 7 bits of audio from your course to play for everyone. And my plan would be for us to kind of chat around those topics as we go. Obviously, the majority of your course is actually showing cases and illustrations, which doesn't work in audio medium. But most of these clips that I've selected come from like the prelude that you kind of deliver for each condition as you go through. So hopefully it'll work in podcast form.
Yeah. I'm not the biggest fan of hearing myself talk, but let's get into it.
It could be a new genre of content for us, reacting to our own recordings. It's like a snake eating its own tail.
Yeah, it is. Well, let's hope I don't embarrass myself too badly.
No, mate. I think you'll do all right here. I don't think anyone really enjoys listening to their own voice back. Maybe Trump.
Yeah, probably. Definitely Trump.
Definitely Trump. All right, we'll stay away from politics. All right, let's jump into the clips then. So this first one, I think there's no better place to start really than with your introduction to the very first topic that you cover in the musculoskeletal calcifications course. So I'll click play on that one now.
I wanted to start first with probably the most common calcification that we encounter, calcium hydroxyapatite deposition disease. Usually we leave the calcium off of this and we just call it HAD, or hydroxyapatite deposition disease. So the disease is already in here. We don't need to say HAD disease or anything like that. Just HAD is enough to encompass this. And this is broadly understood as a calcific periarthritis, or when it's presenting with symptoms, an acute calcific periarthritis. So this is a broad umbrella term, although some of us will distinguish between what is calcific periarthritis, where we don't have clear calcifications within a tendon, maybe they're peritendinous, versus things that are clearly within a tendon, and we call that calcific tendinosis, or if it's acutely symptomatic, a calcific tendinitis. When we think about calcific tendinosis, we have to understand that while some tendons are affected much more frequently than others, they can affect any tendon in the body. And so while we'll see some examples here in the kind of the typical regions in the shoulder and hip, it can occur elsewhere, and we'll try to show a few examples of that. Why do these calcium hydroxyapatite crystals exist asymptomatically and then present with acute symptoms? Let's take a look at this. So let's put some calcific tendinosis here within our supraspinatus tendon, which is where we see it by far the most commonly. Usually when it's in the tendon like this, it's going to not be symptomatic or may cause a little bit of tendinosis. And you'll notice that I keep saying osis instead of itis because oftentimes these aren't causing active inflammation. And so when we find them on imaging, if we don't have a history that would be compatible with tendinitis, it's a little bit of a misnomer to say calcific tendinitis because it may not be causing any itis at all. But when it does, of course, that can be symptomatic and it can cause symptoms locally. But typically when we're getting someone presenting for imaging because of symptoms, it's because there's an acute escalation in their symptoms where they may have had no pain or very low level pain, and now they have really severe pain, 7 or above in many cases. And it's because that calcification is eroding through the tendon and getting into an adjacent synovial line space. And the synovium reacts very strongly to these hydroxyapatite crystals, and it will become acutely inflamed, sometimes so inflamed to the point that it'll actually sublux the humeral head within the glenoid fossa. Okay, and so here's an example of this calcification migrating through the tendon into the subacromial subdeltoid bursa and causing acute pain and swelling. Similarly, it could go through the other side of the tendon and go into the glenohumeral joint and cause pain and swelling that way. And the third way that it can cause symptoms is actually intraosseous migration. And we see this not uncommonly where the calcium crystals will erode their way into the subjacent bone. And we'll see this kind of subcortical cystic formation at the enthesis or kind of in that general region. And that can also be painful and can cause some diagnostic confusion because now it looks like we're dealing with a lytic lesion. So seeing some calcification in the adjacent tendon can be very helpful to tell us that this lucency that we're seeing on either CT or X-ray is actually a lytic change related to kind of the inflammatory reaction to these crystals.
Oh, there you go, Matt. How'd you cope? Did you find it okay listening to yourself there?
Yeah, I've done enough of this. I think I can tolerate it. It was harder in the beginning, but it wasn't so bad this time.
So obviously when you're doing that lecture, Matt, you have illustrations and you described how that calcium hydroxyapatite was initially in the rotator cuff tendon without any inflammation, and then subsequently you show an image of it bursting out kind of into the bursa or into the joint or into that, subinthesial bone causing inflammation. In my experience with HAD and calcific tendinitis, I think radiologists and often trainees, they often default incorrectly to calcification in or near a tendon to being chronic. They kind of just assume it's been there a long time and that it's not related to the current presentation. They don't even just consider the possibility that actually it is acute and that it is the cause of their presentation with pain.
Yeah, I mean, it does have to start somewhere, and it doesn't occur overnight. But certainly, as with many things, it evolves and changes over time, and it can be severely painful when it's actively causing inflammation, and often is the reason people are getting imaged. So, we can't tell on X-ray alone how much inflammation is occurring, of course, but often there are clues. If we have previous films available for comparison, that can be helpful. But we do need to be on the lookout for evidence of joint effusion, and oftentimes we will see that. And depending on how much of that inflammation is getting at the calcium itself and how much bleeding is occurring, you can actually liquefy the calcium and see that calcium kind of being liquid and in some rare cases even causing what we call calcific bursitis. It almost looks like a bursogram. And then other things to look for would include like the subcortical cyst when you get the intraosseous migration at the enthesis with the kind of crystals can cause a pain with marrow edema as well.
I think you show in the course that kind of calcific bursitis with nice calcium kind of conforming to that subdeltoid bursa. So that's definitely something to look for. So the actual morphology of the calcium itself, maybe look for, pseudo subluxation of the humeral head to imply that you've got a shoulder joint effusion, that kind of thing.
Mm-hmm.
The other thing which you go into in the course is when people fail to kind of spot the calcification because it's superimposed over the humeral head, for example, when you've got infraspinatus or subscapularis calcific tendinosis. And another classic for this is the proximal femur with, calcific tendinitis at the gluteal tuberosity or linea aspera, where the gluteus maximus inserts. On the frontal projection, that's often all you've got, hip pain or something like that. You can easily kind of mistake that calcification for medullary calcification because it's superimposed over the femur itself.
Yeah, and the shoulder equivalent to that would be like a pec major calcification, kind of lower down in the shaft. And for the glute max one, we can profile that with the frog leg if we get a good shot of it. But often, if they're in a lot of pain or they're elderly or something, we might not be able to see that. And then we kind of have to think about this potentially being overlying. And it's kind of true with any apparent bone lesion. Same thing applies for lungs and stuff. If we don't have good orthogonal views or there's something that doesn't seem to be adding up, it's good to think that we could be dealing with something overlying in the soft tissues or even the skin or sometimes artifacts as well.
The other thing I've seen missed by trainees and radiologists is when the calcific tendonitis is not in the shoulder. I've seen a case just recently of one missed at the wrist. I think it was like flexicarpi ulnaris. And I've been guilty of missing the classic longus coli calcific tendonitis in the neck myself on CT in my younger days, not recently. So that's another thing to be aware of, is that atypical locations.
Yeah, I mean, it's important to keep an awareness that had affects or potentially can affect all sites, all tendons in the body, not just the shoulder and hip. So, just kind of having that awareness that anywhere in the body you could be dealing with had is important.
And the other thing I guess I'd say here is that it's not always something you think about on X-ray. Often you'll find it on MR these days because a patient, they may have had an X-ray, it may not have been seen, then they're getting an MR because they've got this severe pain, and you'll see this very, very low signal on T1 and on T2, which is your calcium, which is precipitated out in the tendon and lots of inflammation around it. So it's definitely something that we make the diagnosis of a lot on MR these days, and you've got to be aware of it.
Right. Yeah.
All right, before we move away from hydroxyapatite deposition, in most cases it is calcific periarthritis and tendonitis, as we've discussed, but it can rarely cause a destructive arthropathy. So here is our second little audio clip, and just a reminder to listeners that it can involve the joint itself.
In rare cases, we can get these hydroxyapatite crystals going into the glenohumeral joint and wreaking havoc and causing an extreme, severe, destructive arthropathy that mimics a neuropathic arthropathy or, chronic septic arthritis or something like that. So we have to keep in mind when we see a joint that's getting destroyed, particularly in the shoulder, it's not always one of those entities. Sometimes it's actually hydroxyapatite deposition disease. And we have a term for that. That's called the Milwaukee shoulder. Okay. And so keeping that in mind when you have this kind of humeral head, kind of remodeling and destructive glenohumeral joint disease, that we should be considering Milwaukee shoulder differential, which can be confirmed on joint aspiration with identification of those crystals.
Milwaukee, that's in Wisconsin, Matt. How close is that to you? Does everyone have sore shoulders there?
It's a little ways away. I think about a 5-hour drive. Yeah, I don't know, but there might be a link between sore shoulders and Milwaukee tools, which are also named after Milwaukee,
nice.
Wisconsin. And I have a lot of those, and they're of course my favorite and the best on the market, if you ask me. And I would appreciate if they would pay me for that plug.
Milwaukee Tools, get in contact with us.
Yeah.
Actually, speaking of sore shoulders, I saw pictures of you recently building at your own home this amazing rock wall.
Yeah, we just built our new house. It's been a lot of fun, and my wife and I like to tackle projects ourselves and save money. So we did a lot of the work on our house ourselves, which we could do because our contractor was my brother-in-law, and so he was willing to teach us, which was also helpful, having that kind of family connection. And the rock wall was probably my favorite project we did, but also the most stressful because there's not a lot out there teaching you how to do it. Most things you can DIY by just watching some YouTube videos, but I had to watch a bunch of Russian Instagram reels to kind of gather what they were doing. And so I've got a whole laundry list of videos I've saved on Instagram, and I just kind of made it up as I went. But I think it turned out all right.
The details, the way it looks in the end, like it looks like rock. It looks amazing.
Yeah, we wanted to look like someone went to the mountain and just carved off the side of the cliff and brought it to our house. So that was kind of the goal, to make it look like that. I think it'll become more common. It wasn't terribly difficult to do. I mean, I've never done it before, and I did it myself. So with a little elbow grease and a brave soul, I think you can. Pretty much anyone can tackle it. But it does. If people walk in, they notice it for sure.
Not anyone could do it, mate. You've got some special skills. The other thing, you've got like a fake skylight thing that shows you the sky.
Oh yeah, those artificial skylights are awesome. Because skylights notoriously leak, which is one of the issues. But also, because we're living in this northern climate that gets so cold, I designed our house as a perfect cube to minimize the surface area to volume ratio. And so there's no room for skylights anywhere, and I love skylights. So yeah, we bought these artificial ones. They're like a foot deep or so up, and light kind of comes out at a 45-degree angle and like illuminates the whole backside of our kitchen and stuff. And when you look up into it, it looks like you're looking into blue sky. So it's nice to be able to kind of turn on the sun, especially on the long, dreary winter days we get.
Do you have like something that simulates the sun moving across?
It doesn't move across, but there is one product out there that does it, which was about $40,000 per light. So of course we didn't get that one. This one's substantially cheaper. But this one does change temperatures, so we can set it to sunset, or you can have it kind of track through the day if you
Yeah.
want to do that. So in the evening, we'll turn it on kind of a sunset, which is nice. Most people don't know it's not real until we tell them, and then they have to walk around and stare up at the light and be like, "Oh yeah, I guess that isn't real." So yeah, it's pretty convincing.
Very cool. The other thing I've seen you doing recently, Skalski, is another side hobby of yours is these window, what are they, like stickers that you put on a window that simulates like stained glass?
Yeah. Some people call them window clings or window films. Yeah, it's essentially a sticker. There's no adhesive. You just kind of spray water on the window and then kind of squeegee it, and then it kind of lays. I don't know. Yeah, it's a static cling. But yeah, it simulates stained glass, or well, it can. Most people do these for like product advertising that they for businesses is what the
Right, yeah.
product's designed for. But then I've kind of readapted it and then used my art kind of digital stained glass designs printed on them, and so you have to get up really close to realize it's not real stained glass, which is nice because you can, that's super expensive. Most people can't afford it. And there's lots of windows you might want privacy in and not want blinds in. So that's kind of the use case for it.
Yeah, there's a window at my house. You've now got me thinking that maybe I do need to order an original Skalski for my window.
Yeah, I had an inkling that this was going to be a popular product, and so when we built our house, we put in some extra windows and doors with glass that we otherwise would have just put in regular doors, just so we could put window clings in them. And now my wife is a little bit sad we didn't do more because we just had like frosted glass side lights for our front door, and she's like, "Oh, I wish those would have been clear so we could put your stained glass on there."
Yeah. Well, we better move on to our next topic here, Skalski. So our next little audio clip, it's all about another common type of musculoskeletal calcification that we see, and that is chondrocalcinosis.
So chondrocalcinosis is a radiographic finding which, as the name implies, is calcification in our cartilage or inside the joint. The most common cause of this is calcium pyrophosphate dihydrate deposition disease, CPPD disease for short. And as we know, this occurs in 4% of all adults. And so when we see chondrocalcinosis, typically we assume it's an idiopathic or age-related cause, depending on what study you cite. 11 to 50% of older individuals will have some amount of chondrocalcinosis somewhere in their body, typically in their knees. But it can occur at much younger ages and much more extensively throughout the skeleton. And then we would assume that it is a genetic or familial CPPD disease or due to some kind of underlying pathology such as hemochromatosis, because 50% of all individuals with hemochromatosis will have chondrocalcinosis and 32% of those with hyperparathyroidism. There are some other rare causes which can have some degree of chondrocalcinosis, particularly things like ochronosis when we see disc calcifications. We can have trauma that leads to cartilage calcification and some other rare diseases. When we're talking about CPPD disease or chondrocalcinosis, it's important to recognize that while this can be an acutely symptomatic process and can cause extensive joint destruction in some individuals, it runs the spectrum from being completely asymptomatic all the way to extensive joint damage. And so there's been an attempt to standardize the terminology saying what is asymptomatic CPPD that's incidentally discovered on studies that are obtained for other reasons. When we have acute CPPD crystal arthritis, when we have this inflammatory reaction, kind of like we saw when we got hydroxyapatite crystals in the joint. And so this will present with acute pain and swelling. And so historically that has been referred to as pseudo gout because it kind of presents with those acute onset of symptoms like gout does, but of course due to a different cause and in a different distribution. And then osteoarthritis with CPPD, which is when we have kind of the routine findings of osteoarthritis that we could find in any individual with or without CPPD, but then, just incidental concomitant CPPD disease. And then the one that we really worry about is our chronic CPPD crystal inflammatory arthritis, where the crystals are getting out into the synovial fluid and causing, chronic inflammation and destruction of things like supportive ligaments and destabilizing the joint and leading to premature severe degeneration. So we should try to use some of this terminology to kind of make sure we're all on the same page of where we're at with this CPPD being symptomatic, asymptomatic, or causing joint destruction, or just being incidentally associated.
So yes, terminology is important here, isn't it? Not all calcium pyrophosphate dihydrate deposition is made equal, right? Most chondrocalcinosis you see in the menisci of the knee, for example, is just incidental age, degenerative related deposition. Whereas it's those cases where the CPPD is inciting the problem that we really need to be on the lookout for, right? And start to use that full term, the CPPD How many P's am I adding in here? CPPD, crystal inflammatory arthritis. And the knee and the wrist, I think, deserve special mention here because I see these most often. So I'm going to play 2 combined clips here, Skalski, back to back on CPPD arthropathy in the knee and the wrist.
All right, let's go.
In addition to our calcifications of the menisci within the knee, we start to see these calcifications within the gastroc tendons. And so this is a common associated finding in CPPD disease, is these thin, wispy calcifications in the gastroc tendons. And so while it's in the tendon, once again, this is not HAD or calcific tendinosis, although it is technically calcific and it's possibly tendinotic. This is just a manifestation of CPPD disease. But another interesting finding that we see here is that when we see isolated patellofemoral joint space narrowing, that is presumed to be related to CPPD. That's really the only thing that causes it. These crystals get out into the synovial fluid and they cause this kind of really rapidly accelerated, isolated degeneration at the patellofemoral joint. So that's kind of a key finding that you can kind of stow away, because sometimes we don't necessarily build up enough calcium to be able to see it in the menisci before some of these other destructive changes happening. Possibly, these crystals are depositing in the synovial fluid and not necessarily in the cartilage. So you can actually have CPPD disease without chondrocalcinosis, or at least not a lot of it. And so we do have to keep that in mind. And so when we see this isolated patellofemoral narrowing, they may need a joint aspiration because they may have CPPD arthropathy. So here's an example in the wrist where we see, once again, our calcification within the TFCC, which is typically where we're going to find the most obvious manifestation of CPPD disease in the wrist. But kind of like we saw with the knee, it can cause destructive arthropathy. And the place that we see that manifest typically is at the radioscaphoid joint here, or scapholoradial joint. And when you see the scaphoid eroding into the distal radius, oftentimes that's going to be CPPD arthropathy. And the other thing we have to keep in mind is that we have a lot of really important supportive ligaments in here, and trauma is not the only cause of our quote-unquote Terry Thomas sign. So we always want to be on the lookout for this scapholunate widening in all risks, particularly trauma, but in this case, a rheumatic cause, right? So you can have RA, or in this case, CPPD arthropathy, causing scapholunate ligament widening. And of course, the risk there is that you get subsequent disc deformity and slack wrist as the capitate kind of drops down and pushes in between these two and further spreads this apart and disrupts the whole kind of biomechanical network that has to work flawlessly in the wrist for pain-free function. And so this is a kind of an end-stage slack wrist. Capitate is collapsing into this widened scapholunate interval. So something to keep in mind with our CPPD patients and looking out for the scapholunate instability.
There you go. So again, like HAD being, missed or underappreciated, I've seen many cases of quite florid patellofemoral joint space loss, articular remodeling in the absence of any tibiofemoral compartment degeneration that are just reported as osteoarthritis, when clearly there is underlying CPPD crystal arthritis, driving the process in these patients.
This is just one of those things that when you first learn it kind of seems like trivia, but it's important to be aware of, and it's not all that common. And if you just call these cases degenerative, it's not that helpful in guiding decision making and how to treat these painful knees, which can cause a lot of morbidity for people.
I don't think there's any specific treatment for the CPPD crystals itself, but knowing that you are dealing with a chronic inflammatory arthritis as opposed to osteoarthrosis, may impact the anti-inflammatories or the immune modulating medications that the patient ends up receiving, right?
Yeah, for sure. I'm not exactly sure what they do either, but it can, at the very least, provide insight into other symptoms they might have that were previously unexplained. That could be CPPD-related disease, such as in the wrist, cervical spine, etc., and prompt the clinician to maybe reassess those regions with a new view of what's going on.
All right, let's move away from CPPD. So let's move on to another topic. No need for me to introduce this one, Skalski, because I think you cover it in the audio track. So here it goes.
Let's discuss synovial osteochondromatosis. This can be divided into primary and secondary forms. The primary form is a neoplastic process where we are forming cartilaginous nodules in the joint as a neoplastic process, rather than secondarily to degenerative disease, which is what we can call degenerative synovial osteochondromatosis, versus the primary form, which should be referred to as synovial chondromatosis. And the reason we say synovial chondromatosis is because the ossifying portion of this does not occur until later in the disease course, may not happen at all, or when it is happening, does not mean that there are not chondroid portions which will not be visualized radiographically that can only be seen on MRI or ultrasound. Historically, this was referred to as synovial chondromatosis, but nowadays usually we would just say primary synovial chondromatosis and then degenerative synovial osteochondromatosis for the secondary form. The primary form can be thought of as occurring in 3 different stages. The initial stage is when we have the metaplastic formation of the cartilaginous nodules within the synovium itself. As those are forming then, they will eventually go on to detach, which would be stage 2, which we call the transitional phase, where these cartilaginous nodules will now become intra-articular, floating around in loose bodies and potentially causing symptoms, cartilage damage, erosion, or just joint locking, or sometimes even just pain. And then the third stage is then when they're not producing new nodules, but the nodules that are already in the joint, because they're cartilaginous nodules and because hyaline cartilage generally gets its nutrition from diffusion from the synovial fluid, these things will then continue to grow. And as they grow, of course, it can produce more and more symptoms and more mass effect. That is really kind of the key to both synovial primary and secondary synovial chondromatosis, is that these cartilaginous nodules can grow. And sometimes, particularly in degenerative synovial osteochondromatosis, they can grow quite large. The degenerative form, though, you might ask, where are the cartilaginous nodules coming from, if not the synovium? Okay, when the synovium's forming them neoplastically, then we're going to have a lot of them. But when we're forming them degeneratively, that cartilage is actually coming from the articular cartilage itself as it's becoming frayed and kind of sheared off into the joint. Okay, and so we have this kind of wear on the cartilage here, and we can get little bits of cartilage that are going to fragment off. And once again, because the body gives the hyaline cartilage nutrition via diffusion, those cartilaginous nodules can kind of move around and find a little home in a corner of a joint somewhere. It's often a joint recess like the suprapatellar recess in the knee or the subscapularis recess in the shoulder. And once they're then, they can continue to grow and get larger and produce large ossified bodies that we can eventually see on x-ray, but will be in the context of degeneration, and there won't be as many of them because they're not being formed neoplastically. They're simply becoming formed by whatever bits of cartilage happen to have been shed off degeneratively and not resorbed by the body.
Oh, nicely done again there, Skalski. I really like that point that synovial osteochondromatosis is not always osteo. I've seen many cases where there are actually no ossified or calcified bodies visible at all on X-ray, but when you do the MRI, you see all these small, rounded, cartilaginous bodies in the joint.
Yeah, and there's a lot of stuff that can cause joint pain with little to no radiographic abnormality, which is why it's important to have good access to MRI for people with otherwise unexplained joint pains. But also knowing, in this particular instance, that there may be some subtle findings to look for potentially could be helpful, such as maybe some joint distension, some subtle cortical pressure erosion, if it's been around long enough, which may help you suggest MRI as a follow-up. But yeah, really not a lot to go on in those ones that have no associated calcification.
And because this primary form is essentially a tumor, it's chondromatoplasia, it often happens in joints where you don't typically see degenerative type ossified bodies or think about them. I've got this case of primary synovial osteochondromatosis in the temporomandibular joint on MRI on Radiopaedia, and I show it to a lot of exam candidates, and it's very rare that they ever get the diagnosis correct. But if I show them pretty much the same case but in the knee, they get it correct 100% of the time. Mm-hmm. And I've seen a facet joint is another place where I've seen osteochondromatosis, where the diagnosis took a while because people just weren't thinking about the possibility of it, right? But as soon as you take a close look and you go, oh yeah, look, there are these little rounded bodies inside the joint of fusion following cartilage signal, it starts to make sense.
Yeah, definitely. And kind of like we talked about before with HAD at quote unquote atypical locations, just knowing the distribution of the disease or that it can affect other areas can help you keep it in mind with other joints. In this example, if you see something with kind of these strange, maybe neoplastic looking features or there's some kind of mass type growth around a joint, kind of keep that in your DDX alongside things like PVNS and inflammatory rice bodies.
Just 2 audio tracks to go here, Skalski, if you've got time for them. Yeah. So these last 2 I like because they're kind of getting into some of the terminology that we use and some definitions. So the next one is all about heterotopic ossification.
Now let's talk about post-traumatic heterotopic ossification. So post-traumatic heterotopic ossification is the term I like to use generally when we have some type of ossific appearing structure which looks like it's probably from a previous trauma. And the reason that I use that term instead of something like myositis ossificans is because myositis ossificans should be in a muscle. But particularly when we're looking at radiographs, we can't always tell if it's in a muscle or not. If we have a CT or MRI, then potentially we can be a bit more specific and call it myositis ossificans. But, I think it's probably easiest for everyone if we just kind of lump these all under one big umbrella of post-traumatic heterotopic ossification, although sometimes we could be a little bit more specific. So, of course, fat can have trauma as well and cause fat necrosis that will form an oil cyst and that will calcify. A typical example of that is injection granuloma in the gluteal region. We see that very commonly in older individuals in particular. Of course, ligaments and tendons can be injured and calcify as well. A typical example there would be our Pellegrini striatal lesion when we have post-traumatic calcification of our proximal MCL fibers. So the general progression of myositis ossificans, or just heterotopic ossification generally, is that we have this acute traumatic injury and hematoma formation, and then, whether the degree of trauma and, combined with genetics and environmental factors leads to ossification in some individuals, we will get this dystrophic calcification appearing in that necrotic tissue that will then organize into ossific bone, where we have cortex on the outside, and we start building up this internal architecture as it's forming a trabecular medullary cavity. And then ultimately 3 months and beyond, then we will see this appear as a mature ossified structure. This can be a little bit tricky when you're in these first 2 to 3 months, because this dystrophic calcification can look like neoplasm. It can be painful. It can be mass-like. But we do want to do our due diligence here and try to recognize the associated trauma to prevent these people from going on to biopsy, because these can occasionally be mistaken on the histologic examination as an osteosarcoma, because we have lots of mitotic osteoblasts in this region of developing ossification. So we don't want to misdiagnose someone with an osteosarcoma or something else sinister when it's a routine post-traumatic process.
Yeah, you do see, and you read a lot of different words in radiology reports for this process of ossification, but I kind of like your idea of trying to stick to the term of post-traumatic heterotopic ossification. It's a nice one. I sometimes see people incorrectly use the term heterotopic ossification when you have like a healing fracture with quite exuberant callus formation, but it's not actually heterotopic. Do you have a term that you use for those ones, Skalski? Like, is it hypertrophic callus or something?
Yeah, just like you said, I like that term, exuberant fracture callus. I think that makes it exactly clear to all involved about what's occurring. But yeah, when you're dealing with heterotopic ossification, as with many things, we really do have to take in the history or seek it out, because they do look mass-like and they can be mistaken for neoplasm, and certainly, fairly so. Kind of digging in and making sure that there's some history of trauma to explain it, or lack thereof. I mean, because we do want to find those neoplastic cases as well, of course. So really emphasize making sure you get a good history when you're dealing with your MSK cases.
The other thing I'd say is that there are locations where trauma tends to occur, and therefore where the heterotopic ossification or myositis ossificans is likely to develop. For example, it's likely to be deep around the femur in, vastus intermedius or whatever, because that's where you're going to get the muscle injury when you get hit on the thigh. So, when you're seeing something that isn't in those typical locations, maybe there isn't a history of trauma, then that's when you might be thinking about cancer as a cause. But when you do have these locations that are typical of trauma, you've got a history of trauma, and you're seeing something that is, ossified in the muscle or in the fat, then calling it heterotopic ossification is going to do the patient a lot of good and prevent a lot of unnecessary investigation.
Yeah, for sure.
Should we move on to the final audio track here, Skalski?
Yeah, let's go.
A terminology-related topic I find a bit confusing, so hopefully this will clarify it for people listening in.
All right, metastatic calcification and tumoral calcinosis. I put these both on the same slide because they're often kind of mistaken for one another, and so we want to talk about the terminology here a little bit. When we're talking about metastatic calcification, we're talking about some other disease process that is leading to abnormal calcium and phosphorus handling. This is typically going to be renal failure and or hyperparathyroidism. Of course, secondary hyperparathyroidism or renal osteodystrophy is related, although you can have a primary hyperparathyroidism leading to these buildup of calcium masses periarticularly throughout the skeleton, and that would be considered metastatic calcification, which, that term is a little bit unfortunate because it is not a metastatic disease causing it. It's just that the calcification is spreading, and so it's not a neoplastic process per se. Potentially we could come up with a better word for that, but that's the word that we use, so metastatic calcification. And then tumoral calcinosis, we should reserve for the genetic disease that we see often present in young age.
Yeah, so to quote from the Radiopaedia article here, Matt, on tumoral calcinosis, it says, the term should be strictly used to refer to a disease caused by a hereditary metabolic dysfunction of phosphate regulation associated with massive periarticular calcinosis and should not be used to refer to soft tissue calcification in general.
Right. Yeah. Terminology is important here. And just because a term seems to fit an appearance as a descriptor, it doesn't mean it's the right term to use. And this is just one of those cases. But certainly, I mean, we could be better at naming things. As the term people should be using in most of these instances, metastatic calcification falls along the same lines, is that it's a bad descriptor for what it is because it has nothing to do with metastasis. It's good to know the terminology, but maybe going forward, someone can fix both of those up.
I think every single condition to do with calcification should be named after a different city in Wisconsin. That's what I'm going to propose.
I like it.
It'll just make it easier.
I'll name them all. I'm in Eau Claire area, Chippewa Falls. They're all a lot of native names, so they would be unique.
Nice.
That's for sure.
Well, that's it, Skalski. We have made it to the end of the audio tracks that I have lined up here in my little app. Thank you for allowing me to play those for our listeners, and thank you for developing this brand new Radiopaedia course.
Yeah, my pleasure. I hope everyone enjoyed those clips and will equally enjoy the course.
Yeah, we've only really touched on a small amount of the content in your course here today. So it's not only filled with case demonstrations and illustrations, but perhaps what I appreciate most, Skalski, is just all the great tips and insights that you just seem to naturally drop in along the way throughout the recording. So I highly recommend it for everyone listening in, along with your other courses as well. Skalski, you've got one on bone lesions and lumbar spine X-ray and cervical spine X-ray interpretation. All of them come with AMA PRA Category 1 CME credits. Matt, thanks for being here, and I'll see you again sometime soon.
All right, thanks. Talk soon.
See you, mate. There you go, the great Matt Skalski. He's an absolute pleasure to collaborate with that guy. What did you think, Gaylord? Actually, first of all, what did you think of the format of playing actual audio clips from the course? I know we have a CT physics course, a posterior fossa tumor course, and a rectal cancer MRI course coming out over the next little while. So it might be a podcast format that I go back to again.
I think it worked really well, actually. I must admit, I haven't watched Matt's courses in their entirety, but listening to those clips actually made me want to go back and watch the whole thing, which I think is kind of good, right? As far as other courses are concerned, I can't speak to the physics or rectal cancer one, but the posterior fossa one is mine, which I've just finished. And there's probably more than one podcast of me, as I have a tendency to just go off on tangents and rambling.
I think you're missing the point of this fantastic new format of mine. The idea is that I select out the audio clips for playing. So all those unnecessary tangents will be magically removed and it'll fit into one neat little episode. Now, is there anything that you want to chat about from that discussion with Skalski, Gaylord?
Well, I wanted to bring up skylights.
Oh, yes.
I only bring this up because Matt did first. We renovated our house some years back, and the bathroom we have has a square light well up in the roof, which is angled at maybe 30 degrees because it's a pitched roof, and it's topped by a skylight. Anyway, when the skylight was installed, we looked up the well, and the skylight didn't cover the whole space. It was kind of missing a third. And it turned out because when the builders ordered the skylight, they looked at the top-down view of the plans and saw that the hole was square. So they ordered a square skylight, even though it's at 30 degrees. And so I'm waiting whenever my kids turn around and say, why do I need to know trigonometry, Dad? I'm never going to need this. And it's like, you do, buddy. Even the builder needs to know trigonometry.
Especially the builder.
Yes.
Gosh. And didn't you get a leak in that bathroom as well? Was that related to the skylight?
We got a leak, but it wasn't related to the skylight. The first time we used the shower, water started pouring out of the kitchen range hood, which seemed like people had connected the wrong pipes together.
Yeah, the air goes through there, not the water.
Oh, the joys of renovation. I'm sure Matt doesn't have any problems like that because I bet he's extraordinary at DIY, just like he is at everything else he seems to do.
Yeah. We actually have a huge skylight in our house as well in the renovation. And it's got this nice automated external blind that you put across to keep the sun out when you don't want it and then let the sun in on days when you really want it. So, yeah,
Yeah.
it's fantastic. The only bad thing, though, is dirty rain, which
Yeah.
inevitably happens within like a day or two of me cleaning those windows. It's unbelievable. Have you got anything actually MSK related that you wanted to chat about for this
I
episode?
I did like the importance Matt placed on distinguishing between tendinitis versus tendinosis. I don't know about you, but some of my trainees and even my colleagues seem to think that being particular about these kind of differences is just pedantic and meaningless, like the difference between sprain and strain. Now, I know this will come as a shock both to you and our audience, but I am slightly OCD and a little bit pedantic. But I still think that these distinctions are important, not just because you should be trying to be precise as a radiologist, but also, and this I think is the more selfish reason to get this right, is that the words that you use are a way of social signaling to your reader.
Mhm.
And whoever's reading your report, if they know the difference and you use the wrong term, they'll immediately notice that you're using the wrong one, just like spelling mistakes or grammatical errors. And then, well, they're going to sort of judge you based on those little things. It might not be fair,
Mm.
but it's still natural for it to happen. So I think we should be pedantic and particular about the words that we use, even if the distinctions are somewhat meaningless, like sprain and strain. I mean, that's a typical example where it's just convention which one
Yeah.
you use. But any orthopod reading it, if you get the wrong one, there'll be an eye roll there.
Yeah, yeah. So it's pituitary neuroendocrine tumor for you all the way, rather than pituitary adenoma, Gaylord.
I've been toying with the idea of putting pitnet in brackets after pituitary adenoma, but there's a fine line between being current and up to date and socially signaling that you're a wanker. And I'm not convinced which side of that line pitnet lies at the moment, so I've refrained.
You are a complex web of contradictions, Gaylord. Don't want to be a wanker. Just a little bit of a wanker.
Just a micro wanker.
Micro wanker. You need dynamic post contrast to see that you're a wanker. But I guess adenoma isn't really wrong, is it? Because they are tumours arising in a gland. So it's a little bit different to saying itis when there isn't inflammation in a tendon.
Right.
Yeah.
And one last thing, I had another one that's sort of related and that I really empathized with is metastatic calcification. I think that is such a dumb term. I had a great case of this just the other day, which came from a GP particularly, and I felt compelled to include no evidence of malignancy immediately after the conclusion saying that this was metastatic calcification. And it's not so much for the doctor who's reading it, who presumably knows or at least should know or can easily find out what the term means, but for the patient. And this is particularly relevant probably all over the world, but in Australia with the impending changes to My Health Record.
Yeah. So for non-Australian listeners, My Health Record is this scheme whereby health records are uploaded to this centralised repository that patients can access directly, and they have the opportunity to opt out. And up until now, only around 20% of radiology reports actually ended up being uploaded there, but that's about to change.
Right. The numbers were really low, and it was left vague when the reports should be uploaded, and it was left to the individual practices. And some hospitals had, for example, a 2 or 3 week delay between issuing the report and then uploading it. And the idea was to ensure that patients had a chance to see their specialist or GP first to discuss the results. And now the federal government is set to make it mandatory to upload all pathology and diagnostic imaging results immediately, unless you opt out as a patient. And I know medicine has a bad history of being seen and being paternalistic, but the thought of putting a report out there with the conclusion tumor progression or colorectal cancer with pulmonary metastases or something that the patient is potentially reading that evening on their way home from the hospital, days, maybe weeks before they're going to see their doctor, I think is really foolish. And I think that means that we need to adapt our reports even further to take into account the fact that patients may be reading them before they see their doctor. So, I think we need to be circumspect with the terms that we use, but a term like metastatic calcification is prone to being misinterpreted. What do you
Yeah.
think?
No, I agree. I think this is one of those situations where the public think that having access to these reports is empowering to their healthcare, and the public is obviously the majority of people in the community. So the politicians just do what the majority want. But in reality, I think, it will create more anxiety. There'll be more phone calls to your doctor asking, I've read this report, what does this mean? More unnecessary work, and it won't actually help health outcomes. So, if the clinicians could get access to all the patients' previous scans, the actual images in a central
Yes.
repository, then that would be a different story, right? That would be a
Yeah.
massive win for patient care and for efficiency. But that doesn't seem like it's going to happen
No.
anytime soon. It's just the reports and it's the patients accessing them.
Yeah, no, I agree. I think it's, and I actually worry about, the occasional suicide or things in the spur of the moment where there's no context. I can only imagine what it's like living with a malignancy that you've been treated for and finding out that it's recurred and finding out, at 11 o'clock at night when you've had a few things to drink and you're on your own and you don't have any supports.
Yeah.
I don't think that's the right context, and I think it's very short-sighted
Well, you look at the number of emails we get, the number of comments on social media posts, on podcast episodes that are simply from patients who are anxious or confused about things that they've read in their reports. I can only imagine that's going to increase in the future with this kind of thing. Although I will say that a lot of the traffic on Radiopaedia is likely to be lay people searching for things that come up in their report. So maybe it's good for Radiopaedia, more traffic numbers for us.
Yeah, maybe, although that's very much not what we're pitched to. And, and I think there's something to be said for having a language that is, and people will use the word elitist, but it's technical. It's technical and it's precise and it has specific meanings. You shouldn't be expected to write everything in a way that can be interpreted by everyone.
Yeah.
I think that's really hard, which reminds me, I'm just looking at it on my shelf. Do you know the webcomic XKCD?
Yes, yeah.
He also does the What If stories, which are fantastic. He did a book called A Thing Explainer.
Yeah.
It's by Randall Munro. And it's this beautifully illustrated hardcover, large format book where there's sort of breakdown diagrams of all sorts of stuff like rockets and mobile phones and
how to build a rock wall in your house.
Yeah, all sorts of things. But the reason it's called the Thing Explainer is that everything in it is described using the 10 100 most common words, not 1,000, because the word 1,000 isn't in the top 1,000 most common words. And so when you see the Saturn V that went to the moon, it has hole for people in it as the capsule, and burning thing pushes metal can up.
Yeah. Well, that's the thing. I mean, you need to think about your audience when you're constructing your written communication. And when we're constructing written communication for a radiology report, we're thinking about the clinicians reading it. We previously haven't been thinking about the patients reading it. And as you start to think about the patients reading it, it changes how you write the report.
If the government really wants this, then they should fund us more to issue 2 reports. One for clinicians and one for layperson's interpretation, which comes back to our emojis.
Yeah. Yeah. Instead, they're saying you don't get paid for this report unless it's uploaded to the centralized health record. Interesting. Anyway, I think we better wrap this episode up. Gaylard, how can people get in contact with us?
Well, you can email us at podcast@radiopaedia.org with any ideas and or feedback. And you can join the Radiopaedia community chat by visiting radiopaedia.org/community.
Yes, I read out a bit of a funny, critical, woke email last episode. So I've just found a quick one, which is more positive to read out this week. So this one's from Elizabeth, a radiologist in the great state of Pennsylvania. And she writes, "Hi, Andrew. That's a strong start. Left Frank out. That's perfect. OMG, I need that MRI song you made as a downloadable song on Spotify. You should create a band and upload that as your first song. It was amazing. Love your creativity. You remember that song, Gaylard? An MRI beat with the rad tech doing the vocals over the top as if they're talking to the patient. Stay still. Some of my best work.
I do. It's memorable, if nothing else. But, if dogs barking Christmas carols is a thing, then I don't see why this can't be published also.
Now, for balance, Gaylard, I have found a comment that mentions you specifically. Okay, This one is from Spellmaker on YouTube, and it says, "Thank you, Frank. Don't know who Andrew is, but you should kick him out."
What?
And the great thing about this one is that YouTube handle, Spellmaker, is definitely one of my children or potentially my wife.
I haven't considered getting my kids to troll you online, but it's worth a shot. As I was driving yesterday, I think, out of the blue, my 14-year-old said, "Hey, Dad, do you know what happens if you push the brake pedal and the accelerator at the same time?" And I was about to go into a frank, detailed explanation of how that's probably bad, and I'm not sure if there's automatic cutouts, but that rally drivers do. And he goes, nah, the car takes a screenshot.
This is beautiful because you thought he was asking a serious question and he's just gone, nah. You didn't even know a joke was coming. Perfect. Blindsided by your own child.
Happens all the time.
And if you want to help support Radiopaedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle-income countries. And what else can people do to help us out, Frank?
And you could also leave a 5-star review in the podcast app of your choosing. That would be great.
That would be great. And a comment specifically for me or for Frank, whichever. But just something that's divisive, that would be
divisive, political, racially motivated, anything.
Yeah. And as I've said the last few episodes, let your colleagues and friends know about the podcast. That's probably the best way to increase the number of people who are listening in and learning.
Before I sign off, the number of times I've had people not come up to me and say, I listen to the podcast, never admit that they listen to the podcast, but then sneak in a stay rad in an email.
Oh, really?
Yeah. Like my outgoing fellows, one of them, who never said anything about the podcast. I said, it was really great working with you. Stay in touch, blah, blah, blah. And it's like, blah, 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 blah. And then stay rad, smiley face. And it's
Well, I'm always surprised by the people who come up to me and say that, I was just listening to your podcast in the car on the way in. And it's not necessarily the people you expect.
That's cool. In fairness, most of the podcast is not specifically radiology related.
Yeah, that's true. That's true. It just comes on. I'll listen to it, whatever. I'll read this final line. And we'll catch you all again sometime soon in the reading room.
Stay rad, everyone. Catch you next time.
Enjoy Valentine's Day.
I will. I'll go book something quickly.
See you later.
Bye-bye.